Hello and good afternoon, everyone. Welcome to the EdTech Lounge. If you are attending this EdTech Lounge for the first time, although I can see a lot of participants who have been attending these sessions since we have started them last year, April, this EdTech Lounge is a virtual community of practice. Last year, when we were doing this, we were having faculty members each week to share their experience and challenges with online teaching and learning. This year, we are going to hold these sessions every month on a Wednesday. And each month, we are going to have a faculty member who's going to share his or her experience with online and remote teaching. And with this, just before we start, just wanted to share a few housekeeping rules. So I would request you also if you could keep your microphones and your camera switched off during the session. If you've got any queries, questions, or comments, please use the chat. I would also like if you could introduce yourself in the chat. Just let us know your name, the name of the organization, and also the location you're joining this session from. And now, without waiting any further, I would like to introduce our presenter for today, Ms. Zohra Kurji. Ms. Zohra Kurji is an assistant professor and a lactation consultant at the School of Nursing and Midwifery, Khan, Karachi, Pakistan. Since 2012, she is engaged in blended learning and innovation in nursing curriculum. In 2016, she has received simulation training from the Center of Medical Education in Boston, USA. Currently, she is a member of International Nursing Association for Clinical Simulation and Learning. She has also served as a simulation champion and blended learning lead facilitator at CIME and Sonam. She's the only nurse in South Asia holding the award of Certified Healthcare Simulation Educator. So with this brief introduction, I would now like to hand over the microphone to Zohra Kurji to share her experience of simulation and blended learning. So over to you, Zohra.
Yeah, thank you, Abir, for a nice introduction, and hello, everybody. As recently I attended one workshop, and my facilitator taught me that never start the presentation. It needs to be, you have to be include the bridge, and that's why I'm just thinking what could be the bridge for this session. So let's start with one story, that how as a clinical nurse, any this story you can relate easily, how important it is to see the frustration as a clinical teacher. Yeah. So this story, this is me as a clinical teacher. You can see I'm communicating with the students. And once I will share my frustration with you all, I want you to write in your chat box about are you feeling the same while you are dealing the students into the clinicals. So this students was in the interaction with me for the 18 weeks of clinicals. Now, when I assign students to one of the community family, and during the discussion, when I ask from that student, that what sort of medication the family is taking, what sort of hypertensive medication patients on, do you think there should be changing in any regime of the medications, or did you, in your health assessment, did you observe any side effects? So this student was lost, and she said, "Oh ma'am, I learned about the health assessment in year 2. I learned about the pharmacology in year 3, but right now I'm in year 4 and I'm only learning community health nursing. So I never thought I need to be ready for these sort of question in my clinical rotation, and specifically not with the client, but with the community." So that gave me a real frustration as in being clinical faculty. And then I start thinking on that and reflecting back on our own teaching pedagogy as in taught as a single alone course and not giving a variety of cases whereby student would be ready for giving me those sort of answers where we can see the integration of our curriculum and we can support and help the family. So now in your chat box, please write me few of the comment on this story and then share that, how as a clinical teacher, it is different from them. So are you feeling similar frustration with your students during the clinicals? Okay, participants, I cannot see your chat, but yeah, now I can see the chat. No, again it has gone. So somebody can read it for me if there's
Yes,
anything in the
I
chat.
can
Yes.
I can do that, Zohra. So I have received a comment from Saima Iqbal. She's saying definitely the urge to adapt to new methods is not there.
Mm-hmm. Okay.
And there's another one, transfer of knowledge and application can be tricky.
Yeah, that's true. So do you see your students are responding on your questions according to the courses, not as in holistic curriculum while they are on clinicals? This is the next question in relation. Abir, anything related to that? Otherwise, I will move
Um,
forward.
all right, so I've got a comment right now. So Azra is saying that she's not a clinical educator, but she's facing challenges in enabling school teachers to learn new skills that they can implement in their own schools.
Okay, thank you, Azra. So clinical education is sort of a different challenge while you would like to save the community and the client, and you don't want to miss your students to be any sort of aspects where, they are not responding on your on the critical questions which you are asking and which really require urgent intervention. That's why this presentation will tell you about, what sort of new pedagogy which we can introduce in our curriculum, especially in the classroom setting, where we can think that student can learn more on the given cases. They can, and what literature is saying on that. And then I'll talk about our own Sortel grant and the readiness survey, which we have done with this new VRS technique, and then how much we are ready as a developing country. We'll talk about that. So in this world, everything is in games. You can see a small children are playing. They are having the iPads. They are engaged in games. They learn everything, every single thing via gamification. So why not the medical and nursing education, which requires practice, practice, and practice. So in real simulation environment, we cannot call every single student to the mannequin and the physical space to do those sort of practice. So virtual simulation environment gives you that flavor or that support in which the student can practice as many times as they can, and they can learn into the given cases. So now I will give you the flavor of the case. Like the case is that Mr. Ali was found collapsed in his office by his co-worker, and he was working overtime. He skipped his lunches and dinner, and the project deadline was just very tight with him. Now you find Mr. Ali in his 15th during the emergency ward. He regained the consciousness. Now he's complaining that he's not feeling well and he's really, really tired. So now as a student, you will come up with a medical condition, medication, nutrition. You will start the dialogues and the history taking, and this will include everything which you would like to ask from them. Now, physical examination you will done from A to Z, everything comes in physical examination, then you will start monitoring about the vital signs, about ECG, about temperature and everything. Then you will think what test is required for this specific client. So you will order some sort of test, which might be, as in student point, sometimes right, sometimes wrong, but this gamification will give them idea that either they are just thinking about the right lab test for the client or not. Then you will see that, once you will order some sort of results, immediately on your screen you will get the results of few of the biochemistry results. So here are a few of the results. Then you think about the intervention phase, which is really important. So there are a variety of interventions in your screen, and then you pick and choose which interventions you would like to do with Mr. Ali. Then again, there's plenty of medications. So you will think which sort of medication you want to give to Mr. Ali, and which sort of fluid and electrolytes you would like to choose, because there are variety of fluid and electrolytes, and as a nurse it is very critical to choose one of the best with this given situation. And then you will think, what the Mr. Ali is facing at this point of time, and then how you can handle him in the community setting, and how you can manage it. So by the given case, what is your thought as a student, as in faculty, of running this scenario? So I'm just giving 1 minute to you to reflect back on this scenario, and to just let me know in chat box that do you think these sort of gamification will help our student to think critically, and they can able to take the risk to save the Mr. Ali?
So Zohra, I can see in the chat a lot of people agreeing to this. They're saying yes.
Yeah, I can see the chat box as well.
Okay, great.
Yeah, thank you. Thank you so much. Yeah, so let's move further. Okay, so now when we as in faculty think about the VRS, definitely the literature review part is very important, and the literature is supporting the beneficial for the learner, for the educator, that this is a cost-effective thing. The student can repeat the scenario as many times as they can, and it also facilitates the quality of interprofessional collaboration, because few of the students can come up the same time into this virtual environment, and they can interact. They can take their own role avatar, like medical student can take her own role, the physiotherapist can take her own role, the nurse can take her own role, and then they can perform and they can save Mr. Ali in that situation. So we develop in Sonam, the task group is simulation-based education team, and this is my team. With this team, and why we have developed this team, that is the background I will share with you. We know that during this pandemic time, when everybody was on hold, and the clinical education part was very difficult to manage physically in sim lab. So the group of faculty decided to think beyond and to bring some sort of interventions where we can connect our students into the clinical learning and to make them safe for the practice. And this could not be replaced the physical clinical hours, but at least the few of the simulation thing which we are doing was in physically could be replaced. And then when student we can back, we can give them boot camps where they are more ready with their psychomotor skills. So for that, we have planned 3 phases. First, we check the feasibility, that either in our own setting, is it feasible to initiate the virtual reality simulation or not. Then in phase 2, we think about to interim launch of virtual reality simulation. And in phase 3, we have decided that, we will integrate VRS in nursing curriculum by having our own contextual scenario. And that I will let you know that, why we have put the phase 3 based on our feasibility check, which we have done in phase 1. So feasibility, we have done in-depth assessment of all clinical courses using simulation-based education. In that, we have called every course on the table. We, as a team, discuss about it, what sort of objective every clinical course has, and what is the VRS will address those objectives or not. Then we shortlist, we did the pilot testing with many of the software. After all, we decided to do with the Body Interact software company because this was more feasible. They were willing to give us few scenarios for our feasibility as free, and then that was more nursing scenarios was available with them about from the basic till advanced. So for our feasibility, we select 6 relevant body interact scenarios at all levels with the different nursing courses. We develop the tools, readiness tools for the faculty, for the students. Pilot scenarios were run by the faculty, and we have given students a COVID-19 scenario which was freely available on the website. And then we analysis all the data, and that I'm going to share with you. Okay, so this is the level 3 level which I already discussed with you. That faculty readiness was the first level. Student feasibility was the second level, in which we have 32 randomly selected students. COVID-19 scenario. Level 3 was 600 students sent the survey that either they are ready because they were scattered, they were all around the Pakistan, so we really not sure at that time that either they are having proper bandwidth to run these scenarios or not. So we send them readiness tool to test that either we are ready or not. As I discussed with you, we choose the scenario. So these were the 6 scenarios from basic to advanced, and we run with our entire program for year 1 BSc till MScN on different sort of courses. So let's see, this is the faculty faculty account that the total they are the experience previously the software. So majority is saying no, they have not experienced before, and these were the level of scenarios we have attempted from basic to advanced. So these are few accounts. I will run very quickly into it, but a majority of saying that it was easy to access, easy to handle, time was appropriate, logically it was flowed, scenario enhanced critical thinking, and it was according to local and institution guidelines. So majority say agree, but not strongly agree, because that our context of clinical is definitely different than West, and we need some sort of contextual understanding in terms of communication, in terms of time, in terms of overall overall ethnicity and everything. Debriefing was relevant. Yes, it was relevant. Majority think that it gave them the real flavor. Realism is the core of the simulation, which we really need, that student can make a connection that this is the real situation whereby patient or community is in need, and they need to develop some sort of intervention which is safe within and the student needs to be anxious, but they are more confident that this is a simulated case. Either they would like to save, but their psychological safety would be there, and it will not harm to the student's psychological safety as well. Overall comment, yes, it was interesting. It's improved decision making. Few of students may find difficulty because the medical prescription regime was, as I said, every clinical has their own protocols. So it was a basic understanding. Majority faculty think that cultural context is missing, and that's why we planned our level 3, which might be hopeful. Sometimes we will definitely work on this with our IT support and CIME support. So majority also think that this is not a replacement of psychomotor skills, and that's, as an educator, we also think that our student needs psychomotor skills exposure while they are physically present with our task trainers in CIME. So this is level 2 student feasibility survey, and this survey was also run by students from year 1 BScN till MScN, and they also think scenario was, and this is 1 to 4, so 4 is strongly agree and 3 is agree. So this goes like this. So you can see, the 16 responses, how they have given us the response. So it was easy to handle, appropriate in terms of time and space. Scenarios were logical, it was engaging, and the learning outcomes they think they achieve. And as we run the COVID scenarios with them, so the learning outcome was a journal, not a specific to their need. Scenario enhanced critical thinking. So majority says that it enhanced their critical thinking. Debriefing, they said that it was relevant. Multiple attempts, enhanced learning. So students said that yes, multiple learning. First attempt might be they were not that confident, but eventually as the attempt was not fixed, that as many times as they can attempt this scenario, so definitely it enhanced their learning ability to deal. The realism, yes, the students said it was a realism. We can add the nursing curriculum. Majority said yes, they want this to be added in the curriculum. And again, the positive points, overall comments, interesting, engaging, critical thinking, multiple attempts, debriefing, helpful, challenge. Now, this was a very, in this part where we planned this level 3, which was a survey, like time consuming, difficult to access. There was no orientation, so it was difficult for them to navigate. And it was very advanced level, but not the level with the year 1. As I said, it was only one basic scenario of COVID, which we have given to every student. So it was not according to their level of understanding and level of course. So level 3, first we did with the VRS that it requires specific software which is in front of you, from Windows till internet connection till devices, and everything needs to be there while we are running this sort of software, hardware and software as well. So this scenario, as I said, we have sent it to 600 students. Out of 3 to 26 responded, and we receive from them, and this is what they are saying. So as I said, our students were distributed across the Pakistan. So you can see from Sindh, Punjab, KPK, Balochistan, every student were participated in it to give us the readiness that how much we are ready to initiate the VRS within our nursing curriculum. So 70% students have internet connectivity, which can support. However, the quality of connection was medium. It was not that much superb. So we can say that, you know, this scenario can run easily on the system. So 14% students meet the hardware requirement only. So that was again the challenge, because majority of the hardware was not updated with the students. And then they comfort with using VRS. So you can say that, you can see that, you know, majority of students are comfortable. So, but the hardware and software is the issue with them. So the way forward, which we have developed for phase 2 and 3 is that, you know, we will purchase it. We will, when the student will be here with us, we will engage IT person to see more options, how either we can develop one hub from AKU side, where in the hub every scenarios are there, so student can go and retrieve the scenarios from hub, so they don't require that sort of bandwidth in their own home. We met with CIME team, we met with the team of Salim Sayani on to CCIT team, we engage them. We also think about for our phase 2 for the SOTL grant to see a real research questions, and luckily we have received the grant in 2020. So we advocate actually the VRS at many forums. So we developed the formal committee. We did the membership with the INACSL, and then we are also become the member with them. And this all sort of advocacy role we have implemented to bring more mentors on board in terms of nursing curriculum in VRS. So now this is the phase 2 where I will just take you through that, you know, this is not still ready. We have just started the baseline. This is a SOTL grant topic in which we would like to introduce the VRS, and then we would like to see our own journey from need assessment to execution. So aim of the study to do the pilot, and the pilot is ready. We are ready with the pilot. We already buy the software with the 30 scenarios. So now from March onwards, we will pilot it, and in the February, the faculty development training is on, and we will see how effective it is before moving to the phase 3. So these are our research questions. It's to see the faculty development and their competency using it in the clinical teaching strategy for undergrad and grad students. And this is the research question number 2, in which we will want to see on the students that how effective they feel as in clinical teaching strategy. The research question is 3 is how they are satisfied using it. And then 4 is what are their experiences, faculty as well as the students. So this is how we will recruit our sample for the quantitative component from every year, from year 2 to MACN, from BSCN, post-RN program in BSCM. And these are our international mentors, which will support us and help us throughout the study of VRS. And everything is not possible without the wonderful team behind us. So this is the team of Sonam, and we have a great advisor, mentor, dean support throughout to run this VRS initiative in our curriculum. So now I'm open for question and answers, and I'm ready. So let's see what sort of questions as we have from audience. Thank you.